At the start, I just like to say that this is a very interesting topic, and the organizers have very smartly given the topic as monoclonal gammopathy instead of the conventional term monoclonal gammopathy of uncertain or undetermined significance. We will see in what all scenarios this monoclonal gammopathy or amband, as we conventionally call it, becomes significant throughout my talk. This is a brief outline of my talk. I will start with the ambient quantification and techniques, discuss briefly about MGUS and myeloma, and various types of monoclonal gammopathies of clinical significance. What I want to say that we'll discussing more about approach to diagnosis and treatment rather than treatment details in any of these entities. And I won't be covering about myeloma and smoldering myeloma for the interest of time and just going about the overview to approach of these patients. So, what is MBAND? MBAND is a paraprotein. It's a monoclonal immunoglobulin produced by abnormal plasma cells or B cell clone. So, both abnormal B cell clone or a plasma cells can be producing this MBAND, and it's an intact immunoglobulin, can be light chain or heavy chain only, but usually in most of the scenarios, it's an intact immunoglobulin. Production is by B cell, abnormal lymphoid cells. So this can be seen in various chronic lymphoproliferative disorders, abnormal plasma cells, seen in all kind of plasma cell neoplasms, as seen in this picture over here, can be asymptomatic when it is called MGUS or lymphocytosis, smoldering, from the otherwise can have B CLPDs like NHL or solitary plasmacytoma, or can have symptoms from the paraproteins, various kind of symptoms as we will see in this presentation. How do you detect it? Most common method is by serum protein electrophoresis, and this is usually most common initial investigation of choice, where you can quantify the M band. Next is to subtype this M band on the three types, which in IgG, IgA, or IgM. IgG is more commonly seen, but there are certain type of monoclonal gammopathies which are specifically seen with IgM, and we'll see how they are. And light chain, kappa or lambda. So this is how we subtype this. For last decade or so, the new test which is done for these is free light chain assay, where you measure the ratio of these kappa and light chains in the peripheral blood. So for a normal person, this ratio is 0.26 to 1.65. If it is low, either lambda being produced or kappa being produced. So if it is abnormal, that is when you suspect a monoclonal gammopathy. The other method is mass spectroscopy. It's usual nowadays less and less because of its availability and cost issues. However, it is a very sensitive method where it can detection is of the tune of 0.001 gram per deciliter. Consider this as compared to monoclonal gammopathy detection by serum protein electrophoresis, where the detection limit is around 0.5 gram per liter. What happens with the pathogenesis of monoclonal gammopathy to myeloma? What we have here is a B cell in the germinal centers. When there are certain kind of hyperdiploidy or cyclin D dysregulation or epigenetic abnormalities, they form these abnormal clones in interaction with the stromal cells. This asymptomatic stage is called MGUS. Now, when new acquired mutation in the NF-kappa B region or secondary IDH translocation or certain other translocation or mutations occur, in addition to interaction with these mesenchymal stem cell, it forms an asymptomatic stage which is called a smoldering myeloma. And when further mutations acquired, like MYC locase translocation, P50, P53, P18, or other secondary mutation, and in further interaction with the bone marrow milieu, it forms a malignant plasma cell. So this is the clinical stage in which end organ damage begin to appear. If we go into the definitions, MGUS is of three types: IgM, non-IgM, and light chain. IgM MGUS is when IgM monoclonal protein is less than 3 gram. Bone marrow lymphoplasmacytic infiltration. The reminder word lymphoplasmacytic. It's less than 10%, and there is no symptoms attributed to it. Here, the risk of progression is around 1% per year, and it can progress to Waldenstrom most commonly, rarely to AL amyloidosis or IgM myeloma. For the non-IgM MGUS like IgA or IgG, the definition is same, only the clonal plasma cells is there. The risk of progression is lower, and progression is mostly to myeloma and rarely to other subtypes. For light chain MGUS, it's the abnormal light chain ratio. One of the light chain is increased. No other heavy chain expression is seen, and there is no end organ damage. The progression is slightly slower in this case, 0.3% per year, and it usually progresses to either light chain myeloma or AL amyloidosis. There are certain variables which can determine the risk of progression, including the size of M protein, subtype, ratio, immunoparesis, aberrant plasma cells in the bone marrow, DNA ploidy, evolving index, involved light chain ratio if it is very high, so on and so forth. If we go into the epidemiology, luckily we have had multiple population-based studies on the incidence of MGUS. And one of the earlier studies was from Sweden when they were able to determine that it is affecting around 3.1 and 2.5% of subjects. 2.5 we consider more than 25 adults, and 70 years adult around 3%. In the US population, so the incidence is increasing with age at reaching up to around 9% in patients above 85 years of age, as compared to around 3% in patients above, in candidates above 50 years of age. Other parameters are like it's more common in men, thrice common in black patients, more in obese, and familial incidence is there slightly more. There are certain air carcinogens or pesticide exposure which have been linked to evolution to MGUS in normal population. How do you follow up such a patient? If you have a suspected MGUS, there are certain low risk features like low amount of immunoglobulin less than 1.5, IgG subtype, and normal free light chain ratio. Or if there is an IgM subtype or light chain ratio less than 8, if there are no other complication, you go for bone marrow biopsy. It can be done or can be deferred in such scenario. If there are unexplained symptoms or other lab features of concern, barring these, in this scenario, you usually proceed for a bone marrow biopsy. You can consider other imaging in such patients also. How do you follow up? You just look at the last column. We follow the International Myeloma Working Group classification, and follow-ups are a low-risk patient at around 6 months, and then every 2 to 3 yearly. Others every 6 monthly. Test usually quantification of the M band, CBC, and usually a kidney function test is done in such scenarios. What about high-risk patients? There is certain role of imaging in such scenario. If there is IgM kind of protein, you do the routine imaging. However, if there is non-IgM protein where the risk of progression to smoldering or multiple myeloma is there, in such a scenario, you consider for a low-dose whole body CT. If it is not available, consider MRI or PET scan in such scenarios. And if there are any focal lesions on MRI or any osteolytic lesion, you consider this patient for biopsy. So, MGUS can progress to smoldering and can progress to myeloma. The keyword here is can. As you see, the risk of progression to myeloma is pretty low in non-IgM MGUS. What can we do? So, if the patient is of high risk, you increase the intensity of observation and follow-up. Otherwise, there is some potential role and some trials which are even giving anti-myeloma-like therapy to monoclonal gammopathy patients. This interesting test, celecoxib, has been tried in such patients and is in clinical trials. Dendritic cell vaccine has been used. And if the patient has a polyneuropathy, that is neurological kind of symptoms, in those scenarios, you can consider rituximab as well. Now we see that in this Venn diagram, we can see that MGUS is a huge number. Of these, myeloma forms only a minority. Smoldering myeloma is there. And two related disorders, AL and amyloidosis and Waldenstrom, are also commonly seen in an overlap kind of patient. But there are other host of syndromes which can be seen, like cryoglobulinemia, POEMS, cold agglutinin disease, sclerotic edema, and so on and so forth. The proportion of these individual syndromes is not very common. But if you exclude the myeloma patients in these, the proportion increases significantly. When are these patients referred to us? When there is a suspicion of Waldenstrom macroglobulinemia or amyloidosis, or the patient has intermediate to high risk MGUS, or there are features of other MGUS related disorder, that is monoclonal gammopathy of clinical significance like renal, neurological, cardiac, so on and so forth. I just finish off briefly about Waldenstrom first. So Waldenstrom presents with anemia very commonly or hyperviscosity like syndromes. Other presentation can be in the form of neuropathy or cryoglobulinemia. Patients may have hepatosplenomegaly on examination or anemic related symptoms. And rarely, occasionally, they can have B symptoms, which portray a high risk feature. How do these patients, how do you evaluate these patients? So, what the malignant cells are basically pleomorphic B lineage cells, mostly lymphophile plasmacytic cells. So, these are lymphoid cells, remember, and a small clone of plasma cells is there. This is important to remember because while determining treatment, you give a lymphoma or a chronic lymphoma kind of treatment in these patients. So flow cytometry is characteristic. The diagnosis is usually again requires in current era, it requires the presence of mid mutation, MYD88, this L265P mutation, which is present in 90% of the cases. Or if it's absence, you go for a CXCR mutation. There are other certain mutations like AXL or P53, which can also be seen in high risk patients. These tumor cells are arranged in the intertrabecular pattern in the marrow. So, how do you proceed for treatment? If this IgM kind of a MGUS asymptomatic, you do observation only. If there are symptoms like neuropathy or hemolytic anemia, you can consider only rituximab without any maintenance. If there is hyperviscosity, you have to consider for urgent plasma pheresis and starting therapy for these patients. If there are other symptoms like bulky lymphadenopathy or cytopenias like hemoglobin less than 10 or platelet less than 1 lakh, or hyperviscosity or other constitutional symptoms, you have to give chemotherapy in such scenarios. Most commonly used agent is bendamustine rituximab. Just be sure that if the M-band level initial are very high, more than 4 gram per deciliter, in such a scenario, there are chances of rituximab flare and exaggeration of symptoms with first cycle of rituximab. In this scenario, what we commonly do is we give bendamustine for the first cycle, let the M-band come down, and then give rituximab in the subsequent cycles. BTK inhibitors like ibrutinib and zanubrutinib are very tolerable and very emerging therapies in this regard, and commonly used as second line agents in Indian settings. Briefly about amyloidosis. So amyloidosis is usually a multi-system disorder, but many a times one or the other organ system finding predominate. So starting from top, it can present with stroke or dementia. Macroglacia is a common symptom, or dysphagia can occur. Carpal tunnel syndrome or arthropathy can occur. Dyspnea or respiratory failure can occur when these light chains are deposited in the lung. Cardiac amyloid can lead to heart failure or arrhythmias, which is a common cause of mortality in these patients. Patients can have hepatomegaly or involvement of the gut leading to chronic diarrhea, weight loss, malabsorption. They can have easy bruising or nail dystrophy, bruising because of various coagulation defect or neuropathy-like symptoms. So when these symptoms are present, you go for lab tests like serum immunofixation, urine immunofixation with 24-hour urine proteins, and free light chain ratio. If these are any of these are positive, do a bone marrow aspiration biopsy and a fat pad aspirate, usually from the abdominal fat. If these are positive, go for typing. If these are negative and the clinical suspicion of amyloid is high, in such scenarios, you have to go for target organ biopsy like kidney biopsy or even cardiac biopsy in certain scenarios. If these initial tests are negative, then the possibility of ATRR is more likely. In such a scenario. If available, you can go for technetium scan, and if ATRR are likely, go for sequencing. Again, if the scan is negative and the suspicion is high, go for the target organ biopsy. So, just briefly about renal amyloid. So, what we have is amyloid deposit in the glomerulus. These congruent mesangial expansion, which are show apple green birefringence on congruent staining. Then, this is a kappa chain on the I and lambda chain absence. Electron microscopy shows unbranched randomly distributed fibrils. So, this is how the diagnosis of amyloid is made in the clinical settings. Okay. Briefly about just treatment. So, treatment of amyloid is based on myeloma kind of therapy. And in this scenario, usually if the creatinine is fine, you go for a bortezomib based and lenalidomide based therapy. If serum creatinine or renal dysfunction is more marked, in that case, you go for VCD kind of therapy. Nowadays, the monoclonal antibody daratumumab is available, which has shown good responses in such scenarios and can be used upfront. So next we come to about monoclonal gammopathies of clinical significance. So this entity, MGUS, was initially, said to be existing around 1980s, 70s. But subsequently, various kind of organ involvement like renal, skin, cutaneous, clinical or other organ involvement came into being. Neurological syndromes, even primary capillary leak syndromes, all these syndromes came into description. And what now we have commonly used term is monoclonal gammopathy of clinical significance for all these disorders of which are associated with monoclonal gammopathy and certain end organ involvement. What is the pathogenesis? So these can be because of the autoantibodies. Like in VWD, we have autoantibodies against one virulent factor, type 2 cryoglobulin and rheumatoid factors. Then there can be complement activation like leading to atypical HUS or C3 glomerulonephritis. Cytokine mediated like POEMs, where the cytokine involved is VEGF or unknown mechanisms. Small case. So this is about a 65-year-old male, a history of type 2 diabetes for 20 years with peripheral neuropathy. CBC, KFT, and calcium are normal. Nerve conduction study shows abnormality in all four limbs, sensory motor type. On evaluation, someone did an M-band and it was found to be positive in IgG kappa type. So, this is a classical case of monoclonal gammopathy of neurological significance. We'll see how to approach such patients. So these can be distal acquired demyelinating symmetric neuropathy or CIDP, that is chronic idiopathic demyelinating polyneuropathy. Clinically, we see distal acquired demyelinating symmetric neuropathy can have slow insidious progression. Predominantly, they present with distal sensory ataxia with few motor involvement. Tremors are there, and most of the patients are males. Half of them have anti-MAGA antibodies positivity. CIDP will have a relapsing and a progressive kind of a course. Sensory motor involvement is more commonly seen, and usually all the distal limbs, all four extremities are involved. There is areflexia and sensory involvement can also be seen. Lastly, sensory or sensory motor axonal neuropathy is a less common manifestation and present with distal lower limb sensory signs and symptoms. How to approach such patients? So you have history examination, lab evaluation to other causes. You do anti-MAG and anti-ganglioside antibodies and NCS and EMG. If MGNS is likely, on the basis of these features, you work up for IgM kind of neuropathy, that is Waldenstrom, IgM myeloma, or otherwise. If MGNS is unlikely, you work for other atypical peripheral neuropathies, including AL amyloidosis, POEMs, and cryoglobulinemia. Host of tests are available, including lab test, Radiologically, you can look for plasma cell clone and deposits otherwise. Pathologic test will be for diagnosis of myeloid, Waldenstrom, or POEMs. So you can have bone marrow biopsy, mid-88, or fat pad biopsy, or nerve biopsy. And NCS and EMG will be early tests in such scenarios. If it's a IgM kind of a neuropathy, for demyelinating type, you do the anti-MAG antibody if they are positive. If they are positive, the diagnosis is distal myelination and no conduction block. No antibodies, CIDP. If this antibody is positive, this interesting syndrome, Canadomat, is diagnosed. Otherwise, this. For axonal kind of IgM neuropathy, three subtypes are there: amyloid neuropathy, tumoral neuropathy, or cryoglobulinemic neuropathy. Certain features are more characteristic, like for amyloid, it's more of a painful distal neuropathy with carpal tunnel syndrome, and cranial nerve involvement may be seen. Fat pad is usually diagnostic. If that is not there, do go for a nerve biopsy. Cryoglobulinemic neuropathy will present with painful distal kind of a neuropathy, asymmetric involvement, and weakness will be there. Other system involvement can be seen like purpura, ulceration, or livedo reticularis. Diagnosis is based on lower complement and CH50 levels. If all these things are absent, go for nerve biopsy in such scenario. For IgA or IgG kind of a gammopathy, peripheral neuropathy, if it is demyelinating, POEMS is your likely diagnosis with increased VEGF level. We'll just see in the next slide how to diagnose POEMS. If VEGF levels are not there or negative, exclude CIDP or go for nerve biopsy. If it's axonal or mixed kind of a neuropathy, check for cryoglobulins. If they are negative, check for amyloid here. So POEMS, like we said, it's based on two things: polyneuropathy, that is IgG or IgA type. IgM is less common in POEMS, and a monoclonal plasma cell proliferation, usually diagnosed on the basis of SPEP and serum immunofixation. Other major criteria are Castleman disease, sclerotic bone lesion, or VEGF factor elevation. Minor criteria are organomegaly, liver, spleen, or lymph nodes enlargement, that is uh, serositis in the form of edema, pleural effusion. Endocrinopathy like adrenal, pituitary, or gonadal. Thyroid is and thyroid and pancreas are not considered in this because of the common prevalence. Otherwise, they can be skin changes, papilledema, or thrombocytosis. Therapy is directed either at the plasma cell clone or the lymphoid clone. So, if there is IgM kind of a clone which is there, in those scenarios, lymphoid kind of therapy is given either with the anti-CD20 antibodies or BTK, that is Bruton kinase inhibitor, ibrutinib or zanubrutinib. If it's a POEM or a myeloid kind of a thing, then the plasma cell are the culprits. In those scenarios, proteasome inhibitors like bortezomib or lenalidomide can be given. For amyloid, we have already discussed the type of therapy. Let's go to renal. Here, the deposits can be seen anywhere in the kidney. They can be organized or non-organized deposits. Organized deposits can be AL amyloidosis, fibrillar, microtubular like immunotactile glomerulonephritis or cryoglobulinemia glomerulonephritis. There can be inclusion of crystalline deposit like light chain proximal tubulopathy or otherwise. Non-organized like monoclonal immunoglobulin deposit is that is LCDD. So this is one of the commoner thing which is otherwise occasionally there can be no monoclonal deposits. And depending on the site, whether these deposits are in the glomerulus, tubular interstitial deposits, or intranasal vascular deposits, patients can have various syndromic presentations. So they can have nephrotic syndrome with amyloidosis or monoclonal immunoglobulin deposition disease, nephritic to nephrotic kind of a syndrome with PGN MID, ITG, and other syndromes. Acute renal failure can be seen with thrombotic microangiopathy, MIDD, or amyloidosis, so on and so forth. This is an interesting study. where they went on to screen various patients who presented with renal monoclonal gammopathies, and a vast majority of them were amyloid. Around 11% of them were MIDD, and the rest were less commonly seen. If they go into the symptoms, so symptoms were more commonly seen with as in the renal involvement, diabetes or hypertension, comorbidities can be there. Most of the patients were having a kappa lighting kind of a involvement. Hematuria was also commonly seen. Risk factors for development of these were abnormal urinary protein more than 1.5 gram with a high odds ratio and significant p-value, and abnormal free light chain ratio. These were seen on the systematic review. How do you approach such a patient? So you do a renal biopsy in suspected cases, look for the type of renal pathology, extent of damage, and demonstrate the monoclonal proteins. Detect the other things in the blood and urine, characterize these clonal proteins, and look for other extrarenal manifestations. And depending on the type, mostly the treatment is directed towards the plasma cell clone if the patient is symptomatic with advanced CKD. For low early kidney damage, some of the patient can be given symptomatic treatment. Otherwise, for cryoglobulic neuropathy, this is usually directed towards depending on the clone, whether it is plasma cell or a lymphoplasmacytic clone, and according treatment is given. Next, let's look at the cutaneous MGUS. What we have here is different kinds of syndromes. Some of these are definitely associated with the plasma cell neoplasms, like Waldenstrom, amyloid, cryoglobulins, plasmacytomas. Then there can be high associations with the MG monoclonal gammopathies like scleromyxedema or sclerodema or other syndromes. Low associations like pyoderma gangrenosum, sweet syndrome, or neutropenic dermatosis, when other causes of such syndromes have also been described. Like we have patients of POEM, or this patient of scleromyxedema, this patient of necrobiotic xanthogranuloma, or this is a rash of Sisler syndrome. So in Sisler syndrome, you have this urticarial kind of rash with the monoclonal gammopathy, with patient presenting with recurrent fever and bone pains. Usually, CRP and is raised and leukocytosis is there. For scleromyxedema, like this patient, the pattern is that of a generalized sclerodermoid eruptions, and there is a triad of dermal mucin deposition, thickened collagen, and fibroblast proliferation. There is mostly evidence of monoclonal gammopathy in such scenarios. Then patient can have this acquired generalized cutaneous later, or this very recently described syndrome of Tempe, where the patient can have telangiectasias like this with elevated serum erythropoietin and erythrocytosis, monoclonal gammopathy, peripheral edema, intrapulmonary shunting, or patients can have idiopathic capillary leak syndrome. So these are uncommon manifestations of monoclonal gammopathies. What about treatment? So these are certain other patients like chain amyloidosis, type 1 cryoglobulinemia, and this patient is of pyoderma gangrenosum. So if the POEMS is there, you give bortezomib or lenalidomide kind of a treatment followed by transplant. For scleromyxedema, IVIG and IMiDs like thalidomide and steroids are commonly used. For Schnitzler syndrome, these are mediated by IL-1. So IL-1 inhibitors like anakinra is very commonly used. Others like scleroderma, bortezomib-based treatment, IVIG are used. For Tempe, bortezomib-based treatment. And for the rest of the other disorders which have uncommon many association with or less common association with MGUS, symptomatic treatment is given. Usually these are managed, the lower half syndromes are managed by a dermatologist and the upper half by the hematologist or oncologist. What about cardiovascular? So various mechanisms are at play. These include AL amyloidosis, autoimmunity, cryoproteins, prothrombotic coagulation abnormalities, calcification, traditional cardiovascular risk factor which are contributing to everything, and vasculitis which can be immunoglobulin mediated or immunoglobulin leukocytoclastic vasculitis. There are certain studies, both retrospective and prospective, which have shown that the incidence of cardiac or CAD or stroke-like abnormalities is pretty high in MGUS patients. The incidence of ischemic stroke, the risk factor ratio can be between 1 to 1.5, and the hazard ratio is reaching up to around 2 to 1.5 in long-term follow-up for these patients. Various autoimmune disorders are also associated with monoclonal gammopathies. These are pernicious anemia, autoimmune hemolytic anemia, PRCA, ITP, EVANS, so on and so forth. Some of these have a definitive association and more commonly seen, and may improve with multiple myeloma-like therapy, like you know PRCA, ITP, or EVANS. If they are associated with MGUS, they can improve with myeloma kind of a therapy. Other, there might be no change. Then there is the syndrome of cold agglutinin disease, in which the patient present with severe cold kind of cold mediated anemia, which is IgM mediated, and the patient had a C3D kind of direct antibody positive with high titer, that is high titer cold agglutinin more than 1 is to 164, 1 is to 64. If the patients are asymptomatic, they can be observed and asked to avoid cold exposure. If the patients are symptomatic, in those scenarios, you do the clonal assessment, give folic acid and thromboprophylaxis for all these patients. If they are very much symptomatic, consider for plasma exchange or warm blood cell transfusions, and the clone-directed treatment, usually with bendamustine rituximab, is the first line kind of a treatment for such patients. Then, for patient with cryoglobulinemia, you do the extensive evaluation for other organ involvement, like in the skin, neurology, renal, or otherwise. Do the investigation like cryopyritin, bone marrow, and complement level prior to starting treatment. For emergency treatment, steroids are to be started and plasma exchange can be done. Otherwise, definitive treatment rests with BR, bendamustine rituximab, or CDR, that is cyclophosphamide, dexamethasone, rituximab kind of treatment, or even BTK inhibitors have been used in these scenarios. Next, about hematological manifestations, other hematological manifestations. So, these are various population-based studies which have shown that the incidence of thrombosis, both arterial and venous, is slightly higher in MGUS patients. And the larger studies, they have shown that the incidence the hazard ratio can be as high as 7 to 8 in this study, or around 5% in these. The patient can have acquired von Willebrand disease or other coagulation defects, in which the multimers are the antibodies are formed against the von Willebrand factor, or can have aberrant deposition of molecular immunoglobulins on the platelet surface target, especially GP3A or GP1B, and or immunological destruction of the VWF. So M-band is IgD type, and these patients, they benefit from anti-myeloma kind of therapy. So if you have an elderly patient in which gammopathy is there and bleeding manifestation is there, this is another disorder you have to think of. Rarer ones, ophthalmologic and endocrinologic. So there can be two kind of syndromes. Endocrine insulin autoimmune syndrome can be there, and in the eyes, corneal copper deposition or crystalline keratopathy can be seen. So if we summarize, these are various therapies of MGCS. What we have here is starting from the renal, neurological, ocular, and skin. Just, if the IgM type is there, we have given lymphoid clone therapy with the bendamustine rituximab or ibrutinib. For non-IgM, it's mostly myeloma kind of a therapy. Same goes for neurological. So IgM, rituximab or ibrutinib. For non-IgM, IVIG or steroids. For skin, cryoglobulinemia, Sézary syndrome, other syndromes are there. Myeloma therapy is usually for refractory or the non-responding subtypes. What is the flip side of diagnosis of MGUS? So what we have is, why should you screen for MGUS? There are certain things like there is increases or infection which might be there with because of decreased humoral or cellular immunity. So you can manage these patients with some kind of immunoglobulin replacement and proper vaccination at their age appropriate levels. There can be increased risk of fractures with reduced bone mineral density. Bisphosphonates can be given to such patients. We have seen that risk of thrombosis can be there when it is combined with other cardiovascular risk factors. You can consider these patients for lifestyle modification and even prophylactic aspirin. The risk of renal failure can be there, regular monitoring and nephrology referral for renal biopsy. And depending on the biopsy finding and the extent of renal damage, you can consider this patient for definitive therapy. Then, besides myeloma and Waldenstrom, these patients are prone for certain other secondary malignancies, including AML, MDS, non-Hodgkin lymphoma, and other solid tumors. So, there are views to follow up these patients on a regular basis. However, that was the better part. The flip side is that many of the patients they report feelings like living on a cliff or falling off any time. There is patient anxiety and psychological distress which occurs. So can be seen in almost 40 to 50% of these patients. And when they refer to a cancer specialist, there is a fear of having a cancer at each visit. Imagine you're calling a MGUS patient after 6 months, so they're always in fear with their investigations. If they are turning to myeloma syndrome, smoldering myeloma, or any of the other kind of clinical syndromes, that fear is always there. What about physician? There is a tendency to overdiagnose, doing population screening, doing more screening for these patients, how to follow up these patients. And yes, there is always a conundrum whether to treat or not to treat such patient. These are difficult decisions to be made in multidisciplinary team. And if the decision is taken to treat, how to treat, that is also a decision left to experts in the field. Lastly, many a time these are expensive disorders to diagnose, and the investigation for follow-up are pretty expensive as well. With the population prevalence of 3 to 5%, the economics of follow-up can go up to $100 million annually. It's a huge amount of money which need to be spent for diagnosis and follow-up of these patients. So this is a summary slide. Just want to highlight that MGUS is a normal finding for many of these patients, many of these population prevalence going up to 3 to 5%, or can be a pre-malignant kind of a feature. Prevalence increases with age. There is a variable risk of progression determined by certain risk factors to smoldering and multiple myeloma. The clinical identities involved with monoclonal gammopathy, they are evolving, and many new entities are being added every 3 to 4 years. You come up with a new entity which is associated with the monoclonal gammopathy. So neurological and renal are pretty much classified now, but more skin manifestations and other syndromes are coming up with to be associated with monoclonal gammopathies. The presentation is heterogeneous. They require high index of suspicion. The workup can be difficult, expensive, and many a times not available at even at advanced centers. So, uh, extensive workup might be required, and which is available at certain centers only. So, many a times you have to send up investigation outside, outsource them, and sometimes investigations are to be outsourced to US or other countries as well. Treatment is defined for some of these entities, variable for others, and the million-dollar question is to screen or not to screen for these disorders. That is still debatable, seeing the pros and cons of screening, population-based screening for these patients. With this, I like to end and just highlight the contribution of Professor Robert Kyle, who has been the pioneer in the field of MGUS and monoclonal gammopathies.
So one question is there in the chat box. Would you advocate incompatible blood transfusion in such cases?
So blood transfusion will depend on you know usually AHA or cold agglutinin kind of a syndrome where you will have such kind of a transfusion requirement. For AHA transfusions, only in emergency when the patient is having hemodynamic compromise or hemoglobin going down to below 4 grams. Definitive treatment is more essential in such scenarios. For cold agglutinin syndrome, yes, you can give transfusion, but uh, more important is to start definitive therapy because whatever kind of blood you are giving, it is likely to be destroyed on a very rapid pace and won't be lasting long in the body. Definitive therapy is to be started. Yes, for very symptomatic patient with symptomatic anemia, you can give blood transfusions.
Okay, so the next question is sometimes patients get M-band less than 1 gram with other tests in normal limit presentation with kidney failure. How to address?
So these are the patients who are diagnosed as monoclonal gammopathy of renal significance. In such a scenario, there is increasing role for renal biopsy, and depending on the type of deposits which are there on the renal biopsy, you decide on treatment. So, like we saw in the slide, most commonly we have amyloid kind of deposits. Other can be they call an immune deposit disease and otherwise. So for amyloid and MIDD, the treatment has been more defined and it's a myeloma kind of a therapy. So that is how you approach such a case. Renal biopsy is more important and complete evaluation depending on the biopsy findings.
Okay, so the next question is
Is there any role of
is there any role of beta 2 microglobulin in MGUS?
So high beta 2 microglobulin is seen in patient with renal failure and has been one of the prognostic factors for monoclonal gammopathies and very high levels have been associated with higher risk of progression in certain studies. But it is not a very uniform association where the risk of progression is higher. If the patient has high beta 2 microglobulin, their chances of progression is slightly higher. But this is to be interpreted in caution in patient with renal failure. Can you say about light chain MGUS?
Yeah, MG because many times FLC ratio will be increased, but individual lambda or kappa not more than 100. Would we still call light chain MGUS?
Okay, so this is tricky. Yes. Uh, these are to be interpreted very cautiously. If the patient are asymptomatic, you can just observe or maybe do a repeat testing after a couple of months. Uh, if the involved light chain is less than 100, the chances of them having any symptoms are less likely and attribution to technically they will be called light chain MGUS, but the chances of progression or otherwise will be very low. Okay, so this is what recently had a patient, particularly
Yeah,
with
with
migraine.
migratory joint pains, mainly in wrist, ankles, shoulders, and knees. Routine investigations showed mildly raised total protein with deranged AG ratio.
Okay, raise couple India, but just within 100. Okay, these are very
Myeloma
typical cases.
showed no M-band but faint IgG kappa with the raised kappa and lambda light chain just above 100 with ratio normal. How to investigate this patient and further should she be followed up?
So, particularly arthritis, this can be a manifestation of autoimmune kind of MGUS. So that can be a contributory thing or other syndromes, including at times, poems and other things and also present with arthritis. Otherwise, occasionally, this can just be a MGUS and the patient might be having other systemic involvement. So those are to be also looked into such scenarios. Your patient might be, middle age or elderly kind of a patient who is like here 50-year-old, 54-year-old patient who is having MGUS sitting as a bystander and having some other symptom, other disorder. With respect to MGUS, certain entities can have this kind of manifestation. Like I said, autoimmune manifestation have been seen. Uh, Maybe in the future we may have monoclonal gammopathy of orthopedic importance as well. So that is something for the future.
Okay, so the next is if M protein is less than 3, but plasma cell is the marrow is around 20%, how to proceed about?
Okay, if the patient are symptomatic, the amount of if the plasma cells are more than 10%, you are dealing with the smoldering myeloma. Okay, in those scenarios, the quantity of M protein may not matter. You go for symptoms. If the patient has a high risk kind of a smoldering myeloma with high 20 to 20 criteria being applied, you can consider them for treatment. If the patient is having symptoms of end organ damage or slim criteria being present, you can have to start treatment for myeloma. So more than 10%, it's not MGUS, it's a smoldering myeloma or a multiple myeloma per se. Next,
I think that was the last question asked. There are no more questions in the chat box.
one more has come. What is the significance of MGUS in less than 20 years of age? Okay, so in one of the studies, the epidemiological studies, so we have seen that MGUS can be monoclonal gammopathy can be seen in around 2 to up to 2-3% of the patients who are less than 25 years of age. So these patients are to be followed up. Initially, they have long life to go. Maybe you don't abandon these patients even after 6 months or 1-2 years of follow-up, and they require a longer follow-up. So it's uncommon, but yes, at larger centers of follow-up, we all have seen patients who even in their 20s being diagnosed as myeloma. So MGUS can be present even at such low ages.
Okay, kindly advise on treatment and prognosis of high risk smoldering myeloma.
Okay, so two kind of approaches. Most of the guidelines say smoldering myeloma need not be treated. Okay, for high risk, you require a more closer follow-up or more more frequent follow-up, I can say. There are certain authorities which say that for high risk smoldering myeloma, usually commonly in the clinics we use the Mayo's criteria for classification of high risk smoldering, and they advocate use of Len-Dex based kind of a therapy or VRD kind of therapy for high risk smoldering myeloma on the pretext that these patients have a very high risk of progression to multiple myeloma, which is a clinical scenario, and they may have end organ damage in shorter term. So they are delaying the progression of smoldering to myeloma in such scenarios with therapy, or in fact, some of the recent study they claim that they are even bringing down to MRD negativity in such scenarios with therapy. With proper consent, uh, out of a clinical trial, you can consider very high risk smoldering myeloma for therapy. I think no further questions.
No other question is there. Okay, thank you, Dr. Mukulagover, sir. Um, thank you to the River Root team. So we ending the master class here only. Thank you. Thank you all.
Thank you, everyone. Thank you.